Remind you, if you have not muted your line, if you can go ahead and scroll to the bottom of your screen, you should be able to see a mute button on the bottom left. If you can go ahead and mute that, that'll help to reduce any feedback. And if you have any questions during the course of the webinar, please feel free to use the chat box. You'll also see that if you scroll to the bottom of the screen, you'll see a chat, and you're welcome to use that throughout the webinar. If we can't get to those questions while we are speaking, we'll definitely touch on them at the end of the program. So I wanted to start with a little introduction on kind of how we got here today. So in 2018, NJ Sophie entered a partnership with Rutgers University, the Blaustein School of Planning and Public Policy, the Planning Health Communities Initiative through a grant with the County Health Rankings and Roadmaps and the Robert Wood Johnson Foundation. You'll hear more about the County Health Rankings and Roadmaps model throughout the webinar today. Robin and Candace were absolutely integral in the data collection process for this project, as well as the crosswalk, looking at the interplay between the different data sets that you'll also hear more about. We also wanted to thank Leanne Von Hagen and Karen Larry from Rutgers for their support and their facilitation in this project. So a little more about the actual project from the grant. This specific project was looking to connect four counties from southern New Jersey. Specifically, we worked with Atlantic, Cumberland, Salem, and Camden counties. The process worked to increase the understanding of health impact assessments, multi-sector partnerships, and health in all policies. The process has sparked conversations and desires to expand the work for us as individuals, but also with NJ Sophie. This project also showcased examples of gaps in community interventions and health outcomes, which are not unique to the four southern counties that we worked with. As a result of digging deeper into the data, looking at how social determinants of health are tied so closely to health outcomes, and the opportunities to utilize resources in a more effective manner, the Community Health Data Alignment Model was born. This model is a novel approach to concerns that exist in nearly every community in New Jersey and beyond. Our hope is that this model will help you begin to bring about a paradigm shift in the way public health professionals and health educators work in communities, both now and in the future. Go to the next slide, please. Okay, so as you take a look at this slide, read along with the questions that come up. And see if you can answer yes to any of them. See if they relate to your work, your current work. Perhaps you love your job, but sometimes you question your long-term impact. Maybe you're struggling to get buy-in from community or the right stakeholders across sectors. You may not feel like you have the seat at the right table. So if you've answered yes to any of these or the ones that are on the slide, we really hope that the Community Health Data Alignment Model will help you better begin to strategize your next moves. The goal is to increase your impact in upstream issues and root causes, which may have a more meaningful impact on the health outcomes. Throughout this webinar, you're going to learn a little bit more about how you can accomplish this, because we all know it's not such a simple task.
Hey everyone. So to go over the three objectives, one of our main objectives is to define the upstream and downstream model. You've heard about it before, but hopefully we'll give you a little bit more context when discussing health programs and interventions. The second objective would be to illustrate how efforts to address social determinants of health can have positive ramifications on health outcomes and lead to measurable change. Objective 3 is to demonstrate how to synthesize various data sources using the new CODA model that can assist in identifying tangible and specific issues and underlying social determinants of health in a targeted community. Next slide.
So we wanted to start off by grounding everyone in social determinants of health and our definition of it. A lot of you probably recognize this from your undergraduate or graduate school days, but we just wanted to reiterate the importance of the definition of this. Social determinants of health are the circumstances in which people are born, grow up, live, work, and age. And these factors affect a wide range of health risks and outcomes, and they are mostly responsible for health inequities, which are the unfair and avoidable differences in health status we see within communities. So different sources categorize these in slightly different buckets. WHO has their own, CDC has their own. We like the Healthy People one. So these buckets are basically saying that these are the things that are most important in determining the course of someone's health. Neighborhood and built environment, health and healthcare, social and community context, education, and economic stability. So these factors are going to have a huge impact on a person's and a community's health. And they're also what we refer to as upstream factors, which Candace is going to talk a little bit more about in the next slide.
Okay, everyone. Just to give you that upstream, downstream analogy, anyone who goes camping knows where you need to get water. The cleanest water is going to be found upstream. The reason why is because there's usually some natural occurrence, like a moose, for example, and things tend to go naturally downstream. So if you remember anything about the upstream, downstream analogy today, just know that you want to hit upstream, and that's our target for today.
Very good. So to put the upstream, downstream in health terms, we see that the downstream issues are things like cardiovascular disease, diabetes, mental health issues, lead poisoning, obesity, substance abuse. But many of us know that by the time we address these issues, it's often too late, and we're just trying to put a Band-Aid on the problem. But unfortunately, this is where we see most health organizations focusing, really because it can be such a huge need, and people need help right away in these areas, cardiovascular disease, diabetes, but we're really trying to ask you all to work further upstream so that we can have a bigger impact. So we're not asking you to become an expert in housing or transportation employment. What we're asking is that you work with partners in housing, in transportation, employment, education, and open spaces. And know that partners in these departments work at a local level, county level, and state level. If you do this type of work, we feel very confident that the results will be much better and have a much more efficient use of money, because these upstream factors are going to have a huge impact long term. You're not going to see results by working with these departments within 6 months. It's going to be a long-term commitment. But we're going to show you how today to identify the upstream issues in your community and the partners to work with to make that switch. Okay, so let's look at an example. So as we all know, diabetes is a huge issue in our country, as well as our state, and even specifically in some communities more than others. It can be very easy to say that people have diabetes because they're overweight, and they're overweight because they eat poorly. And this puts blame on the individual and their individual behavior. If they ate too much, they had too much junk food or soda, they never exercised. But if that was really the case, then we could give everyone nutrition education classes and solve the diabetes epidemic. But we've got to look further. We need to find out what caused the poor diet. So working with diabetes patients, and diabetes is an issue, this is a downstream issue. Looking back further, if you're going to work on the diet, this is more considered to be a midstream issue. You're not going far back enough. But what caused the poor diet? It could be any number of factors. They could have had a lack of access to healthy food. They could be living in a food desert. This is an area that does not have access to a real grocery store, and a whole host of other reasons. Perhaps they're unemployed. They don't have money for healthy food. Perhaps they don't have public transportation to get to a grocery store, or they lack a high school diploma or even the basic knowledge to understand what a healthy diet is comprised of. So if we look at the types of interventions going on, downstream, midstream, and upstream, downstream, an example of a downstream intervention would be free or low-cost insulin so that people could control their diabetes. A midstream intervention would be nutrition education classes. But this is where we want to make the biggest impact, and this is where we want to be working. So how do we focused here. And I'd like to ask all of you too to just think for a minute about where your current work exists. Are you working upstream? Are you working midstream? Or are you working more downstream?
So now we're going to introduce you to the meat of the project, which is the Community Health Data Alignment, or what we'll term the CODA model. As mentioned in the first slide, the County Health Rankings and Roadmaps project with the Rutgers Law-Stream School in 2018 provided us with a platform and partnership to experiment and develop a system to make sense of all the data. Without a framework, it can be unwieldy to look at the pertinent health issues. So as health educators, we asked, why are these counties unhealthy? What the public health community was focusing on in terms of our CHIPs, in terms of our efforts, maybe wasn't right because the health of the 4 southern counties just kept on deteriorating. Knowing about the ecological perspective and that there are more factors that impact health than just individual health behaviors, we then asked what social and environmental conditions further upstream perpetuate or enable these health conditions. Out of that work, we created the Community Health Data Alignment model. The word alignment is important to this framework, and that was a big part of it. The data and our public health efforts were not aligned. And like the human body, when you are out of alignment, you're not as healthy as you could be. Next slide. CODA is a way of analyzing available data to pinpoint your community's most pressing social determinants of health. Step 1 is align the data sources so that you can identify the issues that rise to the top, the issues that have large ramifications for the population at large, and the issues that affect the community most at need. You'll be identifying the downstream issues. Note that we use the County Health Rankings and Roadmaps data, or CHR&R, the NJ SHAD, or the New Jersey State Health Assessment data, and the United Way ALICE report. We'd like to thank our colleagues who intelligently and painstakingly collect this data for public health practitioners to use. And now it's our time to start using them. Using these 3 data sets, like in this Venn diagram here, there's a center where they all converge. This, guys, is the sweet spot of data where all areas of concern align. The second step is to analyze the upstream, downstream. Do some process mapping. We all know what that is. What impacts are upstream that can result in those issues downstream? Finally, step 3 is to incorporate health in all social policies. Here's where the paradigm shift changes. Healthy communities will be built when we do the second alignment, when we align our efforts with other professionals who impact social determinants of health and align their plans with our public health and healthcare efforts. Align our public health goals with their priorities so that there is a synergy of ideas and collaboration. As you can see here, health is the weaving commonality that unites the various fields in seeing a vision of optimal health and equity. Success of implementation is dependent upon 2 things, capacity and communication. Find out where the resources and attention are focused and incorporate health into the process. The public health community can help other professionals understand the health data. Some organizations and groups do not have access to this data, nor do they know how to translate the data into salient points. This is where health educators can apply their valuable skill set. Next slide. So what makes the CODA model different? The CODA model shifts from a reactive approach to a proactive approach to public health by focusing on upstream factors. And like Robin had mentioned, we are not asking of us to be experts in housing, transportation, education, employment, open spaces. We are asking to be at the table and advocate and watch where the plans go so that you can bend their ear and make optimal health choices an option and a priority for them as well. The CODA model builds upon a health in all policies model and incorporates public health data sets so that we can go back to the table with our peers and demonstrate how health is at the heart of all of our efforts. So this presentation, more than anything else, is targeted at training the next generation to see their clear role in advocating for health in all policies. We can learn from the past, find out what motivates others, learn to synthesize and look for all types of data sets and communicate health to others that they can understand and relate in their own work. Next slide.
Okay, so as Candace already mentioned, we have several data sets that were used in the CODA model for the, and you'll see a couple of examples of this moving forward. So we have NG-SHAD, the County Health Rankings and Roadmaps, and United Way ALICE. So the next few slides are going to dive a little bit deeper into each of these sources. But if you're not familiar with any of them, we would really encourage you to take some time offline to explore the websites and also take a look at how they might impact your work. I also wanted to make a note that NJ Sophie has also sponsored a webinar about the United Way ALICE population earlier this year, and it is available on the NJ Sophie website under the Past Events tab. So please make sure you check it out if you're not familiar with the ALICE report. So first here on this slide, NG-SHAD, stands for the New Jersey State Health Assessment Data. This system provides an access to public health data sets, statistics, and information on health status of New Jerseyans. This dynamic interface allows you to look at community profiles collectively or through separate health indicators of interest. You may want to look at substance use or environmental health indicators or access to healthcare, or one of the many that you will start to see on the screenshot at the top of the slide here. The system now also includes visual meters and gauges, pictured here on the slide for Essex County, which can help you quantify your level of concern around specific issues. As you may notice in the slide example, the difference in the indicators for the county level compared to the state and the country, in this case, it is the, for the new cases of chlamydia, it shows that there is a high area of concern. It should also be noted that new indicators are added and updated frequently. It's highly recommended by us and pretty much anybody that's using data to dictate their work to make sure that you're checking back often. Additional indicators, whether it be a new year of information or even new indicators completely, can help to really impact your overall collective understanding of the community that you're working with and their needs. Next slide, please. Okay, so next we move on to county health rankings and roadmaps. This is a collection of data that's used to create annual rankings for counties both in New Jersey and across the United States. County health rankings and roadmaps provides a revealing snapshot of how health is influenced by where we live, learn, work, and play. They provide a starting point for change in communities. County health rankings data is presented in a variety of ways through this source. You can look at individual health indicators similar to NJ-SHAD, but you can also explore the comparison between counties in the same state or throughout the country. In the example on the slide, you can see that the map indicating newly diagnosed cases of chlamydia. I apologize, I think I said that on the last slide and I meant it to be here. This map allows for easy visual comparisons on the rates. So based on the shade of the color of blue, the darker blue indicates higher rates. So in this example, the darker shades are for Essex, Camden, and Cumberland counties. Again, those darker colors indicate higher rates. So the advantage of this data set in this example is that you can dig deeper than what is available in this map. However, maps like this can be a really important visual representation, which can help you determine where you fall in comparison to your own state, but across the country as well. Next slide, please. Okay, so next we look at the United Way ALICE data. This is not often a typical data set that people are looking at to include when looking at a full inventory of the way people live, work, and play. But if you remember back to that social determinants of health graphic earlier in the presentation, one of those things is economic stability, and the ALICE population or the ALICE data set really speaks to the importance of that. So ALICE is an acronym that refers to a person who is access limited, income constrained, and employed. There are nearly 900,000 ALICE households in New Jersey. These are individuals and families who live above the poverty line, but do not earn enough money to afford the necessities of housing, childcare, food, transportation, healthcare, and a smartphone. These societal necessities that determine the course of a person's health and their well-being. So the question is, do you know ALICE? Are you ALICE? According to the ALICE website, ALICE is your childcare worker, the cashier at the supermarket, the gas station attendant, the salespeople in your big box store, your waitress, your home health aide, or an office clerk. ALICE cannot always pay their bills, have little or no savings, and are forced to make tough choices, such as deciding between the quality of childcare or paying their rent. One unexpected car repair or a medical bill can push these financially strapped families over the edge. So when we combine these ALICE families, again, we have nearly 900,000 of them in New Jersey, with the 335,000 families living in poverty. That equates to nearly 1.2 million households with incomes below the ALICE threshold. That translates to nearly 40% of all households across the state. They're walking this financial tightrope. These populations can be defined as the working middle class, the working poor, our minimum wage workers. You heard some examples of professions that may be impacted by this. These are individuals that don't qualify for Medicare or Medicaid, but they can't pay the basic or the limited health insurance premiums. These working individuals are constrained. One instance of a loss of a job or an illness of a family member can push this individual from the ALICE population into poverty. So when we consider these three data sets collectively, it is allowing us for a more comprehensive look at an individual's health, but also the environmental factors that impact life and health. It cannot be understated that the process of sifting through this data can be a really time-consuming process. You're going to see some examples of this when Candace and Robin go through two different communities and counties. It can feel overwhelming to look at these large pools of information and attempt to pull out the pressing areas of need. If you begin with your own county or area of interest, you can begin on a smaller scale and work from there. So we would ask you, why do you think this is important? And I hope that looking at the Venn diagram, as Candace already mentioned, you consider the sweet spot of integrating all three of these data sets. This is our opportunity to identify the most vulnerable population and make sure that our work is being done to have a greater impact.
Okay, so let's take a look at some examples. And I did see a comment that the audio was coming in and out a little bit, Linda, on yours, but I'm on a different line, so everybody just let me know if you're having any trouble hearing me. So we're going to start off with Cumberland County. This is one of the counties that we did the grant project on last year. So to start off, I just wanted to go through the county health rankings model, because this is really where the CODA model is firmly rooted. And if you're not familiar with this model and the site, I encourage you to check it out, but we'll give you just a brief background here. So the model posits that if you look along the left-hand side where it says policies and programs, so the policies and programs that we have in place impact health factors, including your health behaviors, clinical care, social and economic factors, and physical environment, which then impact your health outcome, meaning your length of life and the quality of life. So this model is meant to showcase the wide variety of factors that influence how long and how well we live. And it's meant to emphasize that health is more than just visiting a doctor's office, but it's impacted by everything from our income to what we eat, to the quality of our housing, to the availability of transportation. Now, if you look in the middle section, the health factors, this is divided into 4 categories. And this says that our health outcomes are weighted differently in different categories. So health behaviors are responsible for around 30% of our health outcomes, clinical care 20%, social and economic factors 40%, and the physical environment 10%. So this means, for example, that 40% of a person's health outcome is based on factors like education, employment, income. Sound familiar? So these are very closely tied to those social determinants of health, the upstream factors that we were talking about earlier. So as Linda said, the County Health Rankings uses data from various sources to rank counties within each state. You can look at one county at a time. You can compare counties. You can also, for some data points, there is data available by town or census tracts if you want to get more details into your county. You can also look for some data points at communities of color and the impact on them. So to start off, we're going to look at Cumberland County, which is located in the southern part of the state. So keep in mind, we have 21 states in the in the state, so 21 counties in the state. So the best ranked county would be 1 out of 21. But you'll see that for Cumberland County, for health behaviors, they're ranked all the way at the bottom, clinical care towards the bottom, social and economic factors, 21 out of 21, the physical environment, more in the middle of the road there. And then it's not surprising that their length of life, quality of life, those health outcomes are ranked among the worst in the state. So I want to take a minute here to talk about their CHIP, because part of our process in the CODA model is also looking at what these counties are doing currently. And the most recent CHIP for Cumberland County was written in 2007. And the priorities listed were tobacco, drugs, and alcohol, healthy lifestyles and obesity, heart disease and stroke, and teen pregnancy. For those of you who work on CHIPs in your county, these probably sound very familiar because across the state, these are common ones that we find. But if we look at these compared to the county health rankings model, where do just about all of these fall? In the health behavior section. These are more of our downstream issues like we spoke of earlier. So how do we expect to make a sizable impact on health by only focusing on 30% of the causes? So we're proposing that instead of focusing our priorities on these downstream issues, we instead move upstream to the categories like social and economic factors, housing, education, employment, transportation. So this part is where we showcase our data. And again, in order to pull all of this together, it is a lengthy process of digging through data. On the left-hand side, you'll see the health behaviors pulled out there. So what we did was then cull through the county health rankings data and the NJ SHAD data and pull in any relevant statistics that fell into these categories. Now we've just pulled out a sample here, but I'll go through it and you'll be able to see how some of these issues kind of bubble to the surface and let us know that we need to be working on more upstream issues that eventually lead to these health behaviors and clinical care issues. And as Linda said, the numbers are constantly changing even as we did this presentation. So I would encourage all of you to continually check back. And the data is often, we're all unfortunately have to deal with the fact that data is often a couple years old. The data numbers that we see here might be from 2016, 2017. So we always have to keep that in mind, especially when we're looking at data as it's trending over time. So looking at health behaviors, we see that in the Cumberland County, people have a much higher percentage of not being able to exercise, not having access to exercise. The adult smoking rate is much higher. Adult obesity, much higher. The STDs, I highlighted this. I know Linda highlighted it before in terms of Essex County, but we also interestingly found this to be a huge issue in Cumberland County. So this means that across the state, the rate of new cases of chlamydia is about 385 cases per 100,000 people, whereas in Cumberland County, it's an astounding 720 cases per 100,000 people. So this is a case where we would want to dig in more. What's going on? Why are chlamydia rates so high in the state, in the county? What community partners can we work with to understand this data? Can we look at the data and find out what age groups or what segments of the population that chlamydia is affecting more at higher rates? Could we also look at the policies and programs going on that might affect this? For example, we know from about 2008 to 2016, Governor Christie took away millions of dollars of funding for women's health, which affected several Planned Parenthoods that had to close, several of which were located in the southern part of the state. Could that have had an impact on people's access to be able to get preventive care? Next, teen births, much higher here in Cumberland County than across the state. Another area where you would want to look in further and partner with, whether it's schools, community centers, anyone who is currently working with youth. Going down to clinical care, we pulled out the mental health providers and primary care physician ratio, which were really lacking in Cumberland County. This data point means that in the state, there is on average for every 530 people, there is one mental health provider, whereas in Cumberland County, there is only one mental health provider for every 1,190 people. The same issue we see with a lack of primary care physicians in Cumberland County. Premature deaths. So this is the years of potential life lost before age 75 per 100,000 people. That's 8,300 years of life lost for 100,000 people in Cumberland County. And preventable hospital stays. What's going on with our Medicare population? This is a measure of rates of hospital stays for ambulatory care sensitive conditions per 1,000 Medicare enrollees. So what can we be doing to prevent people getting admitted to the hospital in that population? Moving on now to the social and economic factors, which we really feel is the most important category. High school graduation rate is lower than the state. We see that having some college is much lower than the state. Only 40% of residents have some college, which might not be surprising. Then the unemployment rate is higher. Children in poverty and children in single-parent homes, this set off huge alarm bells for us. There is a quarter of the population of children who are living in poverty, almost half of children living in single-parent homes. And as Linda spoke of before, this is where we would pull in the ALICE data as well for Cumberland County, and we see that 61% of Cumberland County residents are ALICE and under the federal poverty level. So nearly 2/3 of the population who is basically just hanging on by a thread. It's not surprising to see that disconnected youth is high in Cumberland County if you're having so many children in poverty, low rates of high school graduation, going to college. So this is where you would want to look at this disconnected youth. These are kids who have dropped out of high school, who don't have a job, kind of in those later teen years, don't have any strong connection with a job or school. So who can we partner with? Can we look to partner with schools? Can we look for community colleges in the county and see how we can better get those high school kids into community college? Violent crime, another big red flag, 533 cases of violent crime per 100,000 residents, whereas it's 280 across the state. So what's going on with violent crime? We should be looking at more data. What types of violent crime? Is this gang-related issue? Is this domestic violence issues? Is this happening in certain neighborhoods? Can we look at crime data mapped across neighborhoods within a county to see where it's happening and target our efforts that way? Injury deaths as well, much higher across the state, 64 cases per 100,000 people. So, okay, let's dig in here. Is injuries, are they happening because of falls? Are they happening because of poisoning? Or perhaps it's motor vehicle accidents. Perhaps this high rate of injury deaths could be connected to a bad traffic intersection that we could work with transportation partners to try and redo a traffic pattern. So again, what I'm really trying to emphasize is we don't need to become these experts in traffic patterns, but it's about taking this data, as Candace said, and then going to work with our transportation folks, those in education, in economic development and employment, and helping them to prioritize what issues we want to be working on, because we know from the data what's going to have the biggest impact. So I'm going to hand it over to Candace, who's going to take a look at Essex County for us.
Thanks, Rob. So just like she had said, according to the socio and economic factors, I just want to go back to that socio and economic factors slide. The reason why we focus so much on childhood and children in poverty and children in single parent homes, and one of the reasons why NJ Shad and County Health Rankings and a whole bunch of other data sources focus on children in poverty is because 10, 20, 30 years down the road, they will be the ones who have the cardiovascular diseases, the diabetes, the mental health issues that we are trying to prevent. So if we can make their lives better, according to the study of adverse childhood experiences, that is the single most determinant factor of whether a person will have a chronic condition, is whether they had a traumatic experience in childhood, and poverty is one of them. So moving on to Essex County, we've used this model 5 times. So we've used the CODA model 5 times in the 4 counties in South Jersey, and now we're using it in Essex. So Essex is in the upper right corner of the state, completely diagonal from Cumberland. And you can see our rankings. We are 14 out of 21, 17 out of 21 clinical care, 20 out of 21 for the socio and economic factors, and 19 out of 21 counties for the physical environment. So what we wanted to highlight here is that every county is going to be different in the state of New Jersey. Some of you will fare better in other areas than others, but we really want you to dig into the data per county. So if we go to the next slide, these were the CHIP priorities for Essex County's CHIP back in 2006. So that was 13 years ago, as similar to probably other CHIP reports. Cardiovascular disease, diabetes, mental health, childhood-led exposure, and obesity were identified by the public health and healthcare community at that time. But just like in Cumberland, those are targeting the health behaviors in the county health rankings and roadmaps model, which only covers 30% of where people's health behaviors, health outcomes truly lie. So let's take the mental health. What progress have we made in mental health since 2006? Current data shows that Essex County residents, 12% experience frequent mental distress. Poor mental health days, 3 out of 6 out of 30 days. And mental health providers in Essex County, for every 1 mental health provider, there's 550 residents. So maybe we could use healthcare providers. The other issue is that maybe mental health was too broad a topic. Maybe we need to also consider other downstream issues, like the ones on the right side of the PowerPoint slide. I won't read them out to you, but what would happen if we targeted one or maybe some of those issues? Could some of those issues be the cause of depression, anxiety, panic, post-traumatic stress, domestic violence? What if we made a significant dent in any of these areas? Could you improve someone's mental health status if you changed their life in these downstream issues for the better? Next slide. Digging into the data similar to what Robin had shown in her Cumberland slides, but we're going to dig in a little bit differently in Essex. because some of the issues that bubble up to the top for Essex are, as I said, going to be different in every county. The population of Essex County is 796,914. You can see that for adult obesity, Essex County ranks 29%. The state rankings are on the next column. You can make the comparison. Under physical activity, that is 25% of adults aged 20 and over who report no leisure time physical activity. According to the county health rankings, decreased physical activity has been related to several disease conditions, such as type 2 diabetes, cancer, stroke, hypertension, cardiovascular disease, and premature mortality, independent of obesity. Inactivity causes 11% of premature mortality in the United States and caused more than 5.3 million of the 57 million deaths that occurred worldwide. And that was just from 2008. So this information is going to increase over time as the numbers increase as well. In addition, physical inactivity at the county level is related to healthcare expenditures for circulatory system diseases. I want to also highlight for STDs, they use the cases of chlamydia. So that's for per 100,000, 698 per 100,000 residents in Essex are new cases. That's in comparison and almost double the amount that is found across the state. Deaths due to HIV make us wonder what is the access to care and treatment options. Are we screening too late? What are the support systems for those with HIV? Death rate due to firearms and injury. Again, that's almost 3 times the amount that is in the state. And again, it makes us wonder, what are the firearms injury caused by? Is it caused by suicides, homicides, accidental firearms, improperly stored firearms, illegal firearms? So those are types of issues that you want to dig more into the data, and by doing that, you talk to your partners at the county and local communities. Drug overdose mortality rate, even though at this point the state is a little higher and Essex County is 16 to almost 18 cases per 100,000, this number is one of those numbers that may change with the opioid epidemic as well as with other diseases that are coming down the road. Essex County is being one of the areas where drugs are funneled through because of our vulnerability to the ports. This is a number to watch for. Under clinical care, as much as we want to start with children, we also want to start with maternal health as well. The number or percent of mothers who didn't receive first trimester prenatal care is 35%. So what are we doing for prenatal mothers, and why are we missing this vulnerable and very impactful first trimester to get them to start prenatal care, prenatal vitamins, start screening for any types of diseases or family history, maybe get the mother support that they need because maybe this isn't her first baby. Percent of uninsured is then related to that. We have 14% of our residents who are uninsured. We could do a better job, public health, in terms of getting them access to care and connecting communities to resources like our federally qualified health centers and our navigation centers, and promoting that, which is toward the end of the year for open enrollment. And residents without a primary care provider. So while NJ-SHAD data will tell you the percentages that do have the primary care providers, I think it's important for this presentation that we flipped it and showed you the number of residents in percentages without a primary care provider. So while 76% of Essex County residents and 82% of New Jersey residents have a primary care provider, the Healthy People 2020 goal is to have 83.9% across the country, and 90% in the state. So we have a little bit ways to go in terms of getting to that 90% state target when we have so many people who are still without a primary care provider. Next slide, please. So just to reiterate, the county health improvement priorities or county health improvement plans or CHIP priorities in 2006 were cardiovascular disease, diabetes, mental health, childhood lead exposure, and obesity. But those areas are downstream health outcomes. There are social and economic factors, like these listed on the screen, that grind and burden a person's body and mind and are the precursors for developing chronic conditions like heart disease and diabetes. So what would happen if we partnered with those who are working on plans that determine housing, education, employment, and transportation? Could we have an impact not only on these social and economic factors, but on health along the way? Because in reality, health and socioeconomic factors are intertwined. And while I'm speaking to the choir, we need to get that message out to those who are working on those plans. And the issues here will have health condition repercussions, but we won't see them now. We're going to see them 10, 20, 30 years down the road. If we are not focusing further upstream on these social issues in our own county health improvement plans, then our efforts, focus, and resources are misguided. Not to say that we have not done a good job in some of these areas. For example, in 2017, New Jersey reduced the acceptable blood level from 10 micrograms per deciliter down to 5 micrograms per deciliter. And the regulations such as these will have larger ramifications further down the road. But we have a long way to go if we are working from a downstream perspective. In other words, if we are starting where our efforts once the damage has been done. So you can see here that graduation rate is lower than the state graduation rate, and then something is going on between graduation and then college. We are not able to stay in college and graduate, so maybe they need more support. Children in poverty in Essex is 21%, and the number of children on or eligible for free and reduced lunch is 54%. That's over half of our children in Essex County are eligible for free and reduced lunch. Violent crime is up almost 3 times as much than in the state. And injury death rate is 57 per 100,000. Next slide, please. We start this section because food environment index and food insecurity come up in the physical environment, interestingly enough. Food insecurity, 138,050 residents in Essex County are food insecure. That makes up that 17%. Food insecurity estimates the percentage of the population who do not have access to a reliable source of food during the past year. The Food Environment Index, which is the first row at the top, indicates is an index of factors that contribute to a healthy food environment. So the higher the number, the better you are. The lower the number, the less food access you have to healthy food. No access to exercise opportunities. Essex County has 100% access to exercise opportunities. So that's a bonus. However, when we look to the rates of obesity, then we have to wonder, is there an access issue? So while those opportunities are there, how can we make them more available to the people who really need them? As noted in the previous slide, 25% of adults age 20 and over reported no leisure time physical activity. And physical activity is noted to be at least moderate intensity of at least 150 minutes a week or 75 minutes a week of vigorous intensity or an equivalent combination. The 2015 data shows that fewer than 41% of Hispanics are getting the recommended requirement for physical activity versus other demographics. So there is a need for increase of physical activity among the Hispanic population. You can find that on County Health Rankings and Roadmaps. They do an excellent job of now digging into the demographics and the neighborhoods and the communities that need our help. In terms of severe housing problems, this is a percentage of households with at least one of 4 housing issues. That's overcrowding, high housing costs, lack of kitchen facilities, or lack of plumbing facilities. This data here is from the 2010 to 2014 County Health Rankings data. Also on NJ-SHAD, old housing is an indicator for childhood lead exposure, which relates to the information below. The percentage of children under 3 years old in Essex County with a confirmed blood level greater than 5 micrograms per deciliter is higher than the state, and it's because we have old housing, as you can see with the percentage of pre-1950 housing units. Perhaps, though, the physical environment and level of poverty have something more critical to say about public health than we were originally given credit for. Here's something to meditate on. If poverty, lack of economic opportunities, poor mental health services and support, and substance abuse can or may increase the chances of living in substandard housing or places with severe housing problems, what are the chances of experiencing abuse or neglect or violence in these conditions? And what are the chances that poorly maintained old housing has lead paint and a child is chronically exposed so that the brain development is impaired as it is getting poisoned every day? Could they then develop impulse control issues and make poor decisions? Now let's think 20 years down the road. How many of those who are currently imprisoned for violent crimes or misdemeanors have elevated blood levels? And could that have been prevented? As for the ALICE data, 51% of Essex County residents are struggling to make ends meet and or are below the federal poverty level. They are the ones who bear the burden of food insecurity, who live in poor housing units, who are transient, and who are those who need us to advocate for a stronger safety net for them. On this slide, I love the John Lennon quote, "Life is what happens to you while you're busy making other plans." When health and equity are not on the minds of those writing those plans that determine society's health and well-being, where people will live, work, and play and spend their time, and if health is not championed at the upstream level where the plans are being made, a generation later, we may be dealing with the poor health outcomes that is our mission in public health to prevent. In other words, look at these real-life images. They're the result of poor planning and a lack of foresight or vision for the betterment of health in the community and for all. But it was also public health's missed opportunity to insist on that vision of public health for all. We have the benefit of knowing now what will happen if we continue to make plans and perpetuate systems that build poor housing, use cars as the singular mode of transportation, build roads that bypass whole communities, do not remediate old housing, and have loose zoning laws for alcohol, vape, marijuana, close to schools, daycares, and places of worship. We know what will happen when children go hungry and do not have the means to a proper education in their own neighborhoods. We know that people will forego healthcare if they have to choose between food and their family and paying rent and their blood pressure medication. Next slide. So what if we changed the word life and substituted it for health? What if health was in all policies and plans? Because life and health are the same, and we have to make sure that everyone understands that. We could have better outcomes because of it. Our next steps, on the next slide, are that we ask and advocate for you to use the community health data alignment model. Work to convince people that health should be at the table and make health outcomes relevant to all plans and policies. This is our time now to link health to all of these social determinants because they can't do it alone, and neither can we. We are now open for questions.
If anybody wants to type a question, they can put them in the chat if they want.
Thank you, Claudia. I guess we did such a good job, ladies, that there aren't any questions right now. Oh, Tiffany's typing. Okay. Oh, yeah, Tiffany, I'm not sure if you're muted.
I can try to unmute you. Just hang tight for a second. It looks like you're unmuted now. Can you try to speak?
Can you hear me now?
Yes, we can. Sorry.
Fantastic. I was muted in multiple places, I think. Anyway, I was curious whether you know of any counties in New Jersey that are currently using more or integrating more of the social determinants into their chips. Any kind of success stories that you know of?
I mean, I would speak to that in the sense that I think there's more conversation around this idea, but I personally am not aware of a significant change in the priority areas that we're seeing in some of the chips. Cancer, Robin, you have a different experience than my scope.
Well, I think that the state health improvement plan might help drive this. They seem to better understand social determinants of health and the importance of it based on the meetings we've had with them and the listening sessions over the past year. So we're hoping that from the state level down, that will help push many counties into this direction.
I also think that now is the time when people are revising their county health improvement plans. So it's time for us to start saying those old paradigms, which would be easy to roll into because they're still relevant, are not where we should put our focus. So for those counties where you are working or living in that are currently in the process of looking at their chips, now would be the time to make them do the switch over to a larger perspective of social determinants and using this data to find the spots where they can really make an effort.
Thanks.
I would also just
and
say,
it looks like someone at Union County says that they're using these data sets, so that's great.
I believe it was Candace before mentioned this, but that I would really encourage you as, you know, a health educator, if you're a CHES or MCHES, you know that one of our competencies are kind of helping to support the, you know, the profession. And I think for us, this is a real opportunity to consider where our role is here, not only from our professional work, but also the way that we use interns or kind of support the future of the profession. So kind of the paradigm shift that Candace continues to talk about, you know, we can think of this as a long-term investment in, you know, the workforce of the next generation, so to speak.
Anita, can you tell us which slide you wanted us to talk more about? I see it in the chat that you wanted us to explain the model more. You want us to go back to the beginning? We can go back to the beginning of the slide. So just for all of you health educators on the call, this is painstaking work. Like, you have to really go through all of the data for county health rankings, NJ-SHAD, and then pick through and then crosswalk both of them. That one. She said that one. You have to crosswalk both the county health rankings and the NJ-SHAD data. And then you have to bring it home with these issues are going to impact the ALICE communities more readily. They are the most vulnerable. And that's who we need to bring the public health focus to, which I don't think we have really had a chance to do that. So every year, I feel like we're creating more and more data sets that we can, that public health can rely on. And this is a good thing. We just need to continue using them. Is this the slide that you wanted, Anita? All right, so Yeah, we are just emphasizing that we want to marry and partner with those who are writing plans that determine the social determinants of health. Next steps, the model. Okay. So here we're just saying that housing, transportation, employment, education, parks, and open space are already writing the plans. They're already doing it. They're already writing their master plans for a township. They're already writing transportation and safe walking plans. They're already developing economic development plans. Our task and our responsibility is to read those plans and see if health is even mentioned in any of those plans. You may be surprised that health is not mentioned in any of those plans. That means that health is not a priority for them. The priority might be open space and parks, and indirectly, it will increase health and livability. But are they building parks that are in the poor areas? Are they building access to those parks for people who are handicapped? Are there events at the park that will help families to exercise, multi-generational families to exercise? Are there signs that are written in Spanish, knowing that that park or open space is right next to a large Hispanic community? So it is our vision that public health needs to start reading about the plans, learning about the policies, learning about the projects, so that we can bend the ear of those people and say, hey, there's an opportunity here if we make health part of your policy. Because like I mentioned before, you may be surprised that when you read about a building or multi-level housing that's going up, health is not in the housing plan. Or you'll read about a transportation document and their purpose is roads, commerce, and vehicular benefits, but is health in that plan? I hope that answered your question. We would also be happy to help other counties. Like I said, we did the 4 counties, and it's a lot to process. I also did it for Essex County, and it's also a lot to process. It's a total paradigm shift, but we'd be happy to work with you to work and develop this for a specific county so that you can use the data when you develop your chip or when you're talking to other partners, if that's helpful.
So it looks like no more questions. Jonathan, are you still there? Do you want us to close up, or were you going to take care of that?
Yeah, so that finishes everything up. So stay tuned for more. If everyone can fill the evaluation, it should be automatically going out at 12:15. So, and if you want your CHES credits, be sure to do that. And that's it. Have a good day, everyone.
If I can just jump in for one more NJ Sophie plug, we are having a two-location networking event on July 10th. So if you have not gotten an email or haven't checked our website, we are having a networking event up in West Orange at McLuhan's Boathouse, as well as in Long Branch at McLuhan's Pier House on July 10th, 5 to 8. So if you do want to join us, just feel free to RSVP. We're going to be covering the offenders, and we hope to see some of you there.
No, because like you have to keep them. Like.
All right, great.
Thank you.
I believe we have some
Thank you, everyone, for your time. Bye-bye.